Thank you, Sabine, and thank you, Mustafa and Sabine, for hosting such an amazing seminar series. I was just saying before everyone joined as well that I've really greatly benefited from this seminar series, and very high praise. Thank you so much for the praise on the narrative review. I will be presenting on that today, so I guess we can get into it. So yeah, thanks everyone. And so what I'll be doing is presenting a narrative review titled Desperately Seeking Intersectionality in Digital Health Disparity Research. And this is a narrative review to inform a richer theorization of multiple disadvantage. And it was published as part of my larger DPhil study on digital health disparities, which I'll also touch on briefly towards the end of this presentation. So before we get started, allow me to briefly introduce myself. So as Sabine mentioned, I'm a third-year DPhil student in Translational Health Sciences at the Nuffield Department of Primary Care at Oxford. I'm a part-time researcher, and I'm originally from the US, and I came to the UK as a Fulbright scholar to do my master's in public health. There, I specialized in refugee and immigrant health studies as part of my master's. And prior to that, in the US, I worked as a refugee resettlement consultant. So, a lot of my interest in health disparities and now digital health disparities really stems from working with disadvantaged groups and ethnic minority populations. So now all of these things that I've just told you about are factors that contribute to making me who I am as an individual. So my occupation, my gender, ethnicity, education level, my experiences. And this is a concept called intersectionality. And I'm sure most of you are familiar with this concept, but to give a very brief explanation, intersectionality theory is a framework that recognizes the interconnected nature of various social identities and experiences, including race, gender, class, disability, and others, and how they all intersect to create unique experiences of discrimination, oppression, privilege, and resilience. And a more specific definition in relation to health disparities is the intersections of individuals' multiple identities within social systems of power that compound and exacerbate experiences of ill health. And this recognizes that health is shaped by a multidimensional overlapping of factors like the ones that you see on the screen here. So there are three central tenets of intersectionality theory that I'd like you to keep in mind throughout the course of this presentation. The first is that individual lives cannot be reduced to single traits, nor can single traits accurately depict understandings of individual experiences. The second is that person categories or locations are socially constructed. They are fluid, they're flexible, and inseparable. They're shaped by social processes and structures and power relations, and they're also influenced by time and place. And the third tenet is that prioritization of social justice and equity are really important to intersectionality theory. So as I mentioned, as part of my larger DPhil study, I was interested in exploring how published studies of disparities in digital health consultations have defined, theorized, and empirically tested the concept of multiple disadvantage. So we did a review of existing literature from 2012 to 2022 to examine the digital health disparities in disadvantaged groups, particularly focusing on older, low-income ethnic minority individuals and video consultations. And although we searched back to 2012, we found that only one study in our final sample was actually published before 2020. And the reason for this is that technology developed rapidly in the field of digital healthcare, and earlier studies became less relevant because of outdated technologies, for example. However, a few years later, better and more affordable video technologies specifically designed for healthcare were developed, which made the earlier studies less applicable. So similarly, when it came to understanding digital health disparities, there was very little published before 2012, and earlier studies focused more on challenges that weren't very relevant today, such as website provision and public health dissemination through digital television. So to manage the data, we extracted and organized information from the included sources like study design, key findings on health inequalities and web-based care, issues that were raised by the authors, recommendations for promoting health equity in remote care, and any theories or frameworks that were used to study digital disparities. And throughout the process, we continuously moved back and forth between individual papers and our overview of the findings, gradually adding more and more detail. So we can see from the table that's pictured here that the studies included in the analysis consisted of 17 peer-reviewed research papers, including one systematic review, one narrative theory synthesis, 7 retrospective audits of medical records, and 3 quantitative surveys and 5 qualitative studies. And then a further 37% of the articles commented on others' research, reflected on findings from clinical practice, or proposed measures to reduce digital health disparities. So realizing that the initial data set lacked theoretical analysis, we conducted an additional search for theories of multiple disadvantage that could enhance our understanding of digital health disparities. So this search involved consulting experts in the field, referring to key sources, and searching the PubMed database for relevant terms. The synthesis of our findings was shared with a wider group of peers, including experts in health disparity and digital health, as well as individuals with lived experience accessing care. And we incorporated their feedback to refine our synthesis. So there was a couple of key findings that came out of this review. The first is that the literature was sparse. It only included 2 reviews and 17 empirical studies, most of which were published since the start of the pandemic. And of these studies, most of them, 93% of them, were relatively small and undertaken quickly and under the pressure of the pandemic. So for example, they were qualitative studies that comprised of one-shot semi-structured interviews on convenience samples. The second finding is that despite the limitations of the literature, there were substantial digital disparities reported. So things like low household income, older age, ethnic minority background, especially if limited English speaking, were all independently associated with the lower uptake of video consultations. And proposed explanations to this included lack of digital devices and infrastructure, low health and digital literacy, and inability to understand resource materials. The third finding was that proposed solutions in the literature focused on identifying and removing barriers, but the authors generally overlooked the pervasive impact of multiple layers of disadvantage. The fourth was that the disparities found were sometimes dramatic and contrasted strikingly with studies of video consulting that were undertaken before the pandemic. So these studies had framed this as more of an innovative service model that might increase service efficiency, which really contrasted with what we were finding post-pandemic. And the last major finding was that research into digital health disparities, at least in relation to video consultations, has to date been almost entirely descriptive rather than explanatory. So all of the quantitative studies in our data set were designed to generate knowledge about the association between particular patient characteristics and the uptake and outcome of video consultations. And while this sort of knowledge is essential in identifying a problem, there is a risk that these sort of studies then reduce complex and interacting aspects of disadvantage to simple variables. And in terms of the current evidence base, we also found that most publications took 2 approaches to video consultations within disadvantaged populations. So the first approach views video consultations as a means of digital efficiency that would essentially free up staff time so they could attend to the disadvantage in traditional ways like face-to-face. And the second approach centers on identifying and removing barriers to video access among disadvantaged groups, for example, by ensuring that people are equipped, competent, and confident to use the video modality. And this strategy is founded on an individual deficit model, which depicts the disadvantaged as being deficient in certain things like knowledge or confidence or bandwidth. And it assumes that these deficiencies can be rectified by specific inputs like training, practice, or digital upgrades. But this tends to overlook the pervasive impact of multiple layers of structural disadvantage. And the result is a body of literature that is desperately in need of theorization. So when it comes to investigating digital health disparities, obviously, as I mentioned, researchers frequently use descriptive and variable-centered approaches, but this particular approach has its drawbacks. It entails categorizing research participants and treating them as variables, which can oversimplify the intricate and diverse nature of digital disparities. And consequently, the outcomes of these studies are often presented as single axes analyses, as Kimberly Crenshaw terms this. So this existing literature on digital health disparities is not only limited, but it also lacks comprehensive theories that explain how different dimensions of disadvantage interact. And we believe that relying solely on empirical research without robust explanatory theories may lead to incomplete findings. So that's why we've started looking into broader literature to find theories of multiple disadvantage. And I'll mention three, but obviously there's plenty out there, but the three that I specifically focused on for this review included fundamental cause theory, digital capital theory, and intersectionality theory. So fundamental, and I will very briefly touch on these. So fundamental cause theory offers a plausible explanation for this powerful and persistent link between multiple disadvantage and digital disparities. So if we apply it to digital health disparities, it would basically depict the fundamental cause of these disparities to be low socioeconomic status, and that this cause basically operates through flexible resources such as access or lack thereof to money, knowledge, power, prestige, and beneficial social connections. And then we have digital capital theory by Rignetta and Rowe, which explains how people mobilize resources to participate in digitally mediated activities and services. So this theory points us to the hypothesis that traditional forms of capital, such as economic, cultural, and social capital, are converted into digital capital and vice versa. And this provides the conceptual tools to examine how and to what extent this occurs, which ultimately tells us how social inequality relates to digital inequality. And then we have intersectionality theory by Kimberly Crenshaw, which I've already touched on, but it states that systems of oppression are inherently bound together, and they create singular social experiences for people who bear the force of multiple adverse social structures. So going from basically the theories of multiple disadvantage that I looked at in within this narrative review kind of brings me a little bit more to my DPhil study and how I'm using those theories in my larger DPhil work. And I thought it would actually be interesting to talk about how I'm using specifically intersectionality theory in my broader DPhil study. So I'm doing a narrative, so I'm conducting narrative interviews with low-income, elderly, ethnic minority patients, and a lot of my interviewees have been women. And one of those women has been Saima. So I thought I would tell you a little bit about Saima's story. So Saima is an elderly Pakistani woman living in the UK who faces multiple hurdles in accessing healthcare services due to her chronic conditions, her low socioeconomic status, and her limited English proficiency. I interviewed Saima in her home a few months ago in Northeast London, and sitting in her colorfully cluttered and cramped two-bedroom flat, Saima tells me about these memories she has of living in Marala with her husband and her two young boys. She eagerly recalls these weekends that were spent teaching her boys to ride bicycles in the park, chaperoning school trips to local heritage sites, and drinking mango lassi at the beach near their home. And her eyes, they light up as she speaks about how her kind and understanding family doctor listened to her health concerns. But then when Saima moved from Pakistan to England, it led to this loss of purpose in her life as her children grew up, and she found herself struggling to adjust to a completely different country at a much later stage in her life. This loss of purpose, heightened dependency on others, and limited agency all serve as factors that underlie how she experiences her health, well-being, and access to healthcare services. Because she has limited English proficiency in chronic conditions, she struggles to communicate her health issues to her GP. She has to rely on her husband and her children to speak on her behalf during GP appointments, and sometimes her pain and concerns are written off or misdiagnosed because of miscommunication. Basaima recently had a successful video consultation with her GP, but this experience in itself was not without its own challenges. So Saima's son had to assist her with the technical logistics, and Saima herself was stressed and anxious about this video consultation appointment. But because her son was by her side, she was able to communicate her concerns to the GP effectively, and they were able to get to the root cause of her pain. So reflecting on the experience of having a video consultation, Saima summed it up by telling me, it was a better option, but I wouldn't be able to do it on my own. So this statement highlights the multiple hurdles that marginalized patient groups face in accessing digital healthcare services, including reliance on family networks, lack of accessibility to digital technologies, gaps in language and translation support, low health and digital literacy, and sometimes dismissive attitudes of healthcare providers. So what I've done with my analysis of these narrative interviews is to start to create these digital inclusion user personas as one of the main outputs of my DPhil research. So these are fictional characters that embody the needs of a group that's at risk of exclusion and encompasses features that we need to think about when designing and embedding technology-aided services. And they're meant to paint this vivid picture or story of what individuals like Saima's life looks like to better highlight what the gaps are. And the idea here is that care should be guided by questions like, what does Saima need? What does she want? What's important to her when she's not feeling well? What does she need to better access services? And what do health services need to do to meet her needs? And my goal with these personas is to be able to tell detailed stories about patients from my target group that really highlights their intersectionality. And I'll talk you through this persona through the lens of an intersectionality framework. So the way the persona is designed is to encompass the different facets that holistically make up Saima's life with a focus on her healthcare journey. So these include her health concerns, her values and beliefs, her family and social structure, her digital capacity, her healthcare needs and challenges, and then frustrations. And underpinning these different facets of her life are the intersectional identities, positionalities, and oppressions that Saima faces in her day-to-day life. So analyzing these experiences in relation to Saima's intersecting identities, positionalities, and oppressions paints a more accurate picture of what's needed for her to successfully access care through video consultations. And Saima's experience illustrates several key challenges that can arise when transitioning older adults with limited technological literacy to digital health services. So first, the shift from seeing a familiar GP in person to video consultations with unfamiliar doctors has disrupted continuity of care for Saima. So after having the same GP for 15 years, she now feels disconnected from providers who don't know her medical history. And this lack of personalized care makes her feel like just another patient rather than an individual with unique healthcare needs. Second, Saima struggles with the impersonal nature of video consultations. So nonverbal cues that usually develop rapport in face-to-face interactions like smiling and nodding were missing from those interactions for her. So from her perspective, the doctor was not even looking at her in the video call, and this perceived disinterest kind of discourages Saima from openly communicating her health concerns. And the third thing would be the shift to digital health and how that's weakened Saima's sense of agency in managing her care. So she has limited technological skills, and because of that, she has to rely entirely on her son to book appointments and assist during video calls. And this dependency has made her feel voiceless and pushed to the side in her own care. And finally, these negative care experiences have damaged Saima's trust in healthcare services and providers. So unfamiliar doctors, impersonal video interactions, feeling overlooked, and having little control over her care has bred this sense of mistrust. And this trust deficit discourages Saima from further utilizing health services. So ultimately, what does my narrative review and DPhil work tell us about the implications for research? The first is applying an intersectionality framework to study how multiple disadvantage stems from race, class, gender, age, disability status, immigration, etc., and how they all overlook to shape access, attitudes, and usage of digital health technologies. So essentially, an ideal intersectionality framework in its application to digital health disparities, research needs to include a few different considerations. So first, whatever conceptual framework is used, the historical foundations, contestability, and specificity of terms used in reference to it should be clearly laid out. Second, it's important to be clear about what kinds of differences are to be analyzed and also to center critiques of power because the emphasis needs to shift from a preoccupation with identities and categories of difference to an analysis of the interactive processes of differentiation that produce and govern subjects and that subjects generate and resist, and then how these processes work in relation to the systems of domination. Third, as a way to attend to the complexity of an underlying and underlying an intersectionality lens, there is an enormous value in comparing the operation and effects of interactive processes of differentiation and systems of domination relationally across one another and also at different levels. And finally, it's also very critical that the research and policy be directed by social justice agendas. Otherwise, they're not really consistent with intersectionality analysis. But ultimately, within scholarly discourse, I think it's important to view intersectionality as an analytical sensibility that basically goes beyond mere terminology or adherence to established paradigms. Um, Instead, we need to kind of emphasize a profound reorientation of thought towards the complex dynamics of identity, power, and difference in relation to digital health disparities. There was a really great paper by Cho et al., which aptly put it as what makes an analysis intersectional is not its use of the term intersectionality, nor its being situated in a familiar genealogy or its drawing on lists of standard citations, but instead what actually makes an analysis intersectional is its adoption of an intersectional way of thinking about the problem of sameness and difference in its relation in its relation to power. And then secondly, in terms of implications, qualitative methods like in-depth interviews, ethnography, and narrative research are very critical to uncover the nuanced, contextual patient experiences at intersections of identity and oppression in remote health. And capturing these lived experiences through patients' own voices can really illuminate these complexities. Um, and third, we also call for greater interdisciplinary dialogue between theoretical research on multiple disadvantage and empirical studies on digital health disparities, because there is a need to explore the intersectional dimensions of digital inequities and contribute to theoretical and empirical advancements in this field. And then in line with that, it's also in line with that, we also need to look at the pervasive impact of disadvantage and evaluate whether new digital health technologies mitigate or amplify existing health disparities across intersections of identity. And lastly, it's also important to consider designing user-centered digital health technologies that address the multidimensional nature of disadvantage with a focus on partnering with marginalized communities in the research process to ensure that we're really centering marginalized voices in the process of digital health disparities work. And I think that brings me to the end of my presentation. That was quite short, actually. I assumed it was going to be longer.